Hello, welcome to QD Clinic. My name is Dr. Eric Dein. I'm a rheumatologist with Atlantic Health in Summit, New Jersey. And today I'm going to talk about a case beyond the numbers of interstitial lung disease that came into my clinic just the other day. She was a patient who was treated in an outside rheumatology clinic, came in for a new diagnosis of interstitial lung disease, presented initially with dyspnea and cough as her presenting symptoms. She denied any other symptoms, arthralgias, morning stiffness, rashes, muscle weakness, sicca, Raynaud's sclerodactyly, the whole review of systems we all know very well. Her physical examination was notable for bibasilar rales on pulmonary auscultation, but without any other rheumatic findings suggestive of RA, lupus, scleroderma, or myositis. She had a workup done by her initial rheumatologist, which showed a very high positive SSA antibody, negative SSB antibody, and she was started on mycophenolate 1,500 milligrams twice daily. She came in for reevaluation because she was uncertain about this diagnosis of Sjogren's disease and was very poorly tolerating the mycophenolate, had a lot of GI symptoms with it, and she was highly concerned about the idea of being on an immunosuppressive therapy, given the infectious risks, particularly in light of having concomitant lung disease. And she had done some reading on Sjogren's disease, and she said she really didn't have any sicca symptoms to speak of. So I asked her all sorts of different questions about sicca. Um, does she have any dryness symptoms, gritty eye sensation, sand in the eye type of sensation? Could she eat a cracker without drinking water? And she didn't have many symptoms of that. Um, on reviewing her imaging, she had interstitial lung disease with a UIP pattern. It's worth noting that UIP pattern is more associated with the idiopathic pulmonary fibrosis, whereas NSIP is more closely associated with the autoimmune diseases. But that said, autoimmune etiology should certainly be highly considered for both. As an aside, the other interstitial lung disease to think about is lymphoid interstitial pneumonia, which is a rare form of ILD, but it is very associated with Sjogren's disease. She did not have that, so she fit that UIP pattern. We discussed that not all patients with Sjogren's disease have sicca symptoms. Some have pretty significant sicca on objective testing without any symptoms of it, and many patients with Sjogren's do not have any dryness at all on workup. We did an objective test. We did the Schirmer's test in the office. She also did tear breakup study with her ophthalmologist. Those tests were normal. We thought that should be an excellent candidate to get a lip biopsy of her salivary gland to assess for Sjogren's disease via a gold standard technique. And she had a focus score of 0, so did not show any evidence of Sjogren's disease. So despite the SSA antibody, she really didn't have any other symptoms, other examination findings, or other pathologic findings to confirm a diagnosis of Sjogren's. When we see the SSA antibody, I also think about could this go along with lupus diagnosis? Could it go along with myositis diagnosis? She didn't have any features of lupus, had a negative ANA, had no objective weakness, had a normal CK. Um, so not all patients, with positive serologies necessarily have an associated autoimmune diagnosis. Given the ILD, and we see these CT undifferentiated cases that are associated with ILD, you would definitely want to have a high suspicion. But given her ILD and serologic findings, um, we would want to watch her closely, but she had a conversation with us, and we elected to stop the mycophenolate, and we started her on antifibrotic therapy. She had much better GI tolerance with the antifibrotic therapy that she did with mycophenolate. And with pulmonary on board and with careful watching of her PFTs and CT scans, she has done really, really well. So she's had stable findings on her symptoms and her objective testing on the antifibrotic. So this is a patient who we've been able to keep off of immunosuppressive therapy, and her indication remains unclear. So my takeaways and learning from this case is to always treat the patient, not necessarily the numbers. In rheumatology, very few lab findings are in of itself diagnostic of an autoimmune disease in isolation. So always correlating back to the patient, considering the exact phenotype of and different types of ILD to help guide your management. Not all patients have SICA in Sjogren's disease, and not all patients with Sjogren's disease have SICA. But in times of uncertainty, remembering that there's the diagnostic testing to evaluate for SICA, and then there's also the salivary lip biopsy to get more information, more confirmation. And always reevaluate. So reevaluate both your own diagnoses and those made by prior providers, and not to anchor upon one piece of information. So reassess the need for therapies when they're on it, and upon discontinuing, especially always follow and consider if you need to reinstitute that therapy. Hope this was a helpful case, and pay attention to RheumNow for lots more on ILD this month.